Hello everyone, in this video I will be discussing about spinal cord lesions. Today's plan, I'm going to start by talking about spastic hypertonia. So this is something that is found across many different kinds of neurological conditions. I will be talking also about the different types of lesions one can have, followed by a prognosis, which is often kind of misunderstood. And finally, I will differentiate between two different kind of conditions that resemble each other, and they are autonomic dysreflexia and orthostatic hypotension. Okay, so here we have a cross-section of the spinal cord. Here I am going to draw a muscle, and we are going to put here a muscle spindle. If you recall, a muscle spindle is a little sensory organ inside your muscle that detects the change in length. It's going to go up the dorsal root ganglia into the ventral horn, where it will synapse with a lower motor neuron in the ventral horn. Now the lower motor neuron will go through the ventral root and innervate your muscle fibers. So I'm going to write lower motor neuron here, and here we have our sensory neuron. So this is one way to stimulate the lower motor neurons. Let's say you want to move your arm. Well, voluntary movement always starts from the motor cortex. You're going to send signals through the lateral corticospinal tract. This will go down through your spinal cord and will again stimulate this lower motor neuron. So those are the two main ways that you can initiate movement. Now, another thing to consider is that we have other tracts that come down through your spinal cord from, let's say, the reticular formation in the brainstem. And these ones will actually do something else. They will come and synapse with a inhibitory neuron. Will go inhibit your lower motor neurons. So let's say that you have a lesion here, and let's say for the purpose of this video it's a C6, C7 spinal cord lesion. After the lesion happens, you're going to enter a state called spinal shock. So spinal shock is a state of areflexia, which means your whole body below C7 in this case will be completely shut down. So you'll have no reflexes whatsoever, no voluntary movement, because our yellow tract here is compromised, and we have no inhibitory signal either. Now, the next thing that's going to happen is your lower motor neuron will slowly start to wake up. And when it wakes up, it will find out that, well, you cannot control it voluntarily. It's not inhibited anymore. And so the only thing that is stimulating it is the sensory neuron here in blue. What you can imagine is going to happen is it's going to be constantly stimulated by the sensory neuron, and it will be spastic. It's kind of like taking the brakes off of the lower motor neuron. This is what causes spasticity. And you might be wondering why often we find spasticity is often in flexion. Simply that flexors are usually stronger than extensors. Now let's talk about different types of spinal lesions. They can be either complete or they can be incomplete. Now, the difference here is important, and I think it's worthwhile mentioning. A complete lesion refers to no motor or sensory output in the S4 and S5 segments. Incomplete lesions, on the other hand, are defined as a partial preservation of motor or sensory under the lesion and this is important, and S4 and S5 segments. Okay, let's discuss now about the most common locations where spinal cord lesions actually happen. In the neck region, we have C4 to C6. Now this is the main region where we have most fractures, and this is because this is the area of the neck where we have maximal flexion. Okay? And another common region in the spine is around T11 to L1. They're right here. And this is because this is where we have the least flexibility, if that makes sense. Now, I just want to make a quick note on the difference between tetraplegia and paraplegia. So tetraplegia refers to a cervical paralysis, so from C1 to T1. Paraplegia, on the other hand, refers to any lesion under T2. All right. So we discussed about the types of lesions. Now let's talk about prognosis. So as I mentioned before, this is kind of something that is misunderstood by patients, and I'll explain why in a second. So the first element that we have to consider for prognosis is what is the level of lesion, and another criteria would be, is the lesion incomplete or is it complete? And this is where confusion happens. Usually when we have an incomplete lesions, it's mainly caused by a compression of the spinal cord, and so there's no actual tear or break into the spinal cord. Patients will often come up to you and say, well, I don't have a complete lesion. My spinal cord is still okay, so it might be able to wake up. But actually, it's not really the way it works. So yes, incomplete lesions usually have better prognosis than complete ones. But in general, even if you have, let's say, a tetraplegia of C6, C5, C6, chances are you're going to walk are pretty low. There's a point at which there will be no more recovery, and that is usually around 12 to 18 months. Okay, so let's come back to the level of lesion. Clinically speaking, we try to have a common classification system. So when we have a patient with a tetraplegia without triceps, this is a tetraplegia for C6. In the diagnostic, we might have C6 tetraplegia, but clinically speaking, what is important for us is the word triceps. Then the next one would be a tetraplegia with triceps. The patient with motor function in his triceps will be way more functional just because triceps are so important for transfers. And then we have something my professor calls the finger deluxe. And this is because these patients will have preserved motor function for their fingers, And so they have the luxury to use their hands to do different things. Then we enter paraplegia, and we have without abs, and then we have paraplegia with abs, and with abs is the prognosis is a lot better. And again, it's for transfer reasons, just general mobility. So if you have a tetraplegia C1, C2, these patients will not have the ability to breathe by themselves. So we find them on ventilators. C3 to C4, the diaphragm will work. So these patients will be able to breathe by themselves. The tetraplegia in the C5 to C8 regions are quite common, so this one is important. So we have function of the diaphragm, but we also have pectoralis, minor and major. We also have serratus anterior. We also have rhomboids. And most importantly, we have the latissimus dorsi, which is probably the most important muscle to have, functionally speaking. If we go down to T6 to T10, so we'll have all the above muscles that work, but they will also have the intercostalis muscles and abs. It's worthwhile mentioning that C5 to C8 tetraplegias, these patients will be able to breathe quite well by themselves, but because abs and intercostalis muscles are essential for forced expiration, so coughing, the patients for C5, C8 will have trouble exhaling forcefully, so coughing here will be quite difficult. So prognosis is done. So now let's distinguish about two conditions that can happen quite often in spinal cord lesions. So let's start with orthostatic hypotension. So what is this? Basically what it is bradycardia, so low heart rate, combined with a decrease in blood pressure. So what happens is, especially during acute phase, the patient is lying down, not moving, is completely immobilized. And so this decrease in blood pressure is mainly due to the fact that there is low venous return. So muscles cannot push the blood back to the heart. And this is caused by immobilization. When we try to transfer a patient from laying down to, let's say, sitting, if we don't take our time in doing this task, all the blood will go down because of gravity, but his heart rate stays low, and so this can cause dizziness and decrease in consciousness. So why is it? Why can't the heart compensate? Well, okay, let's see here. So let's say we have a C4, C5 fracture. Now we know that the heart is innervated greatly by the sympathetic nervous system. So let's start here at the heart. So we see what innervates the heart. We have this neuron here, this neuron here, this one here, this one, and this one. And if we follow the neuron, so this one comes here, there, this one is related to here and here. We see that the heart is innervated in the thoracic segments and usually around T6. So lesions above T6 have the sympathetic nervous system that is not working, and so it cannot increase the heart rate. And so that's why we have a situation where the patient is bradycardic because of this. So what do you do if this happens to you in clinic? You have to lay them down. That's as simple as that. Now let's look at autonomic dysreflexia. Simply put, we have a situation where we have bradycardia with an increase in blood pressure. Let's come back to our graph here. So autonomic dysreflexia is caused by a pain stimulus that usually originates below the lesion. Usually we find this in the distal part of the legs. And so this pain stimulus arises from the peripheral nervous system, and it will activate the sympathetic nervous system. The sympathetic nervous system will activate peripheral vasoconstriction below the lesion. And so we have special receptors called baroreceptors, and these will sense the increased blood pressure, right? Because if we increase vasoconstriction, we have increased blood pressure. And this will activate the parasympathetic system to try to slow down the sympathetic system. Now, the most important nerve related to the parasympathetic nervous system, especially towards the heart, is the vagus nerve right here, the 10th cranial nerve. And we see here the 10th cranial nerve starts right here, and it innervates the heart. So it's directly connected to the heart, and it will decrease heart rate. And it also tries to slow down the sympathetic nervous system to create vasodilatation, but it can't because here we have a lesion, and anything below the lesion doesn't work. And this creates a situation where we have increased blood pressure because of the sympathetic nervous system, and it creates a situation where we have bradycardia. So yes, bradycardia is caused by the vagus nerve trying to compensate, but remember also that our sympathetic trunk here doesn't work either. And so it can't even increase heart rate even if it wanted to. And this creates a very dangerous system where if it's not solved quickly, you can have a heart failure. You can have a risk of stroke as well, epilepsy, and even in the worst case, death. Okay, so we talked about causes before. So causes, it can be any noxious stimuli, so pain in the legs, for example. Also, it can be caused by a distended bladder. These are the most common ones. And we have a last one, fecal impaction. So constipation, pretty much. Now, this happens not in the acute phase, but more so in the chronic stage of recuperation. And so what do you do when this happens to you? When this happens to your patient in the clinic? Well, you have to sit them up in an upright position. And usually patients will be able to tell you before it happens because they'll feel a little bit dizzy and they'll start sweating. Their face will start sweating. And you can also tell if you see their face kind of flushing up a little bit, becoming red. Those are things to watch out for. In orthostatic hypotension, this is important to monitor in the acute phase. And so usually nurses or even physiotherapists can do this. You take blood pressure laying down, and you measure blood pressure is sitting. If there is a difference of 20 on your systolic pressure over a difference of 10 diastolic pressure, this is usually a clinical sign of orthostatic hypotension. I hope this video made sense, and I'll see you in the next one.